So I'm Linda Clowry here. I'm a paediatrician in Dundee, and I was historically the national lead for the paediatric work stream of McQuick, or the Paediatric Patient Safety Programme. We have started introducing a national paediatric early warning score across Scotland, and we've had requests from a number of the boards about how, really trying to understand how we've managed to develop the national paediatric early warning score, and for them to try and understand why we think it's worthwhile moving it across to all using the same scoring system. So this has obviously taken a few years for us to develop, and therefore we are trying to summarise that few years' worth of work into 2 or 3 short, brief summaries. There's sort of 2 or 3 main areas for us to think about. One is, well, what is the evidence for the best paediatric early warning score? And if we do have evidence for best paediatric early warning score, is it actually the best for all patients in all environments? For us to try and understand that, we agreed that there was 2 or 3 things we had to do. One of them was to undertake a literature review, which is described in another chapter. One was to undertake a Delphi process of really what was the state of play in Scotland at the time we started working on a national paediatric early warning score, and that's what this chapter is about. And then understanding how we were currently using paediatric early warning scores across Scotland, which is described in another chapter. The National Paediatric Patient Safety Programme was launched officially in 2010, but work had started in 2009. And the main focus was really about deteriorating patients. Part of that was paediatric early warning scores, and in those early days there were 5 charts in use. 2 of them had been validated and published. And there was discussion at the outset for the National Paediatric Early Warning, National Paediatric Programme about whether we should have a National Paediatric Early Warning score. But at that stage, the teams who had created their charts were heavily invested in them. They had spent a lot of time in them. They spent a lot of time researching what the current evidence was and what they thought was best. And we were really in the early days of using them. And generally, people felt that whatever system and chart that had been introduced in their board, because they were so heavily invested, they generally believed that it was the best. And we felt it might slow us up with progress, trying to move to a national score at that stage. So in the early parts of the programme, we got on with what we describe as the other stuff, focusing on deteriorating patients. Now we have 14 territorial health boards in Scotland. All of us were focusing on various areas of work, but there was a common language developing and there were common themes developing, and we'd really become reliable with many of the other things associated with recognition and escalation of deteriorating patients. So in all boards we had data being reported on reliability with compliance with safety briefs, using structured handovers, particularly SBAR, on using paediatric early warning scores, on identifying watchers, which is a concept that we've borrowed from Cincinnati, identifying patients who may be at risk even if their physiological parameters are within normal limits or they have a normal PEWS. We'd introduced safety huddles in most units, so these were happening at shift changes and during the day in most units, but going a step beyond that, there were also organisational safety huddles happening in many of the units. And many teams had actually introduced a programme of in-situ simulation. So we felt we'd made a lot of progress in a fairly short period of time on focusing on deteriorating patients. And when we got to 2012, we were kind of starting to think, well, actually, is it time for us to think about having a national paediatric early warning score? And the discussion really focused around about us having a common language. So we developed common language about everything else, but we did not have a common language about PEWS. The issues were really flagged to us by 2 groups of people, one being our patients. So many of our patients are looked after on a shared care basis, where they'll be looked after by their DGH but may have specialist treatment in another centre. And these patients are often frequent flyers. They're in and out of units. They move between units. And there's a degree of frustration being voiced by them that in one unit, such and such a physiological parameter would score X, Y, or Z score, and may lead to a difference in admission criteria or discharge criteria between boards. Now, whether this may seem subtle to us if you were the patient with a delayed discharge or an earlier admission, that can be frustrating. The other group of people who were raising the concern about there not being a common language were staff, primarily our paediatric trainees who move between units in Scotland, but also some of our nursing staff. And they were flagging up that actually, particularly the registrars, were moving between units, and it took them a few days, up to a few weeks, to get used to the new language being used in the new post. So whilst a physiological parameter may score the same in one board, the escalation may be different, or an escalation may be the same, it would involve a different team member or be escalated at a different score. And they just voiced concern that perhaps they weren't responding the way they should do when they moved between posts. The question then comes of which is the best chart to look at. So by this stage in 2012, we'd gone from having 5 charts in use to having 14 in use. We therefore had 14 boards who believed that their chart was definitely the best, and 14 team members who had invested a huge amount of time in creating these charts. Was there any evidence that one was better than another? Was there evidence that actually they were hugely different from each other? We didn't really have an understanding of that. Was there a need to change? Well, the need to change was finally driven by the Scottish Ambulance Service. So 14 territorial boards, all believing they have the best charts. The Ambulance Service then came along and said that they wanted to look at using paediatric early warning scores in the pre-hospital environment. We have a national paediatric retrieval service, we have a national ambulance service. Therefore, there was no advantage to us having 14 different scoring systems in use in the pre-hospital environment. And what happened when you crossed a territorial boundary? So really we were in the position of having to think differently and having to agree that we were going to have to move forward with a national paediatric early warning score. The question was, we didn't really know how easy or how difficult that was going to be at that stage. We had a lot of will, so there was a lot of people keen to look at this, and there was a lot of people keen to drive this forward, and for that reason we felt we might make headway in 2012, where we hadn't done in 2009. What we didn't really have an understanding of was what the main differences were between the scoring systems. So as a national team supporting the safety programme, the Team at Healthcare Improvement Scotland agreed to undertake a Delphi process, looking at what scores were in use across the country. They requested that the charts were sent in from each board for all the age groups, so we could look at them. And essentially what we were doing was looking at the degree of agreement or difference between the charts. So looking at them, there were 15 different things recorded on paediatric early warning scores, charts, in various centres around the country. Some of them were recorded on a chart but not scored. Some of them were recorded on a chart and scored. Not all observations were recorded on all charts across the country. There was relative agreement for 4 measures. So all charts in all centres for all age groups scored for a conscious level, heart rate, respiratory and oxygen saturations. There was relative agreement about temperature and blood pressure. So for those 6 physiological parameters, it was relatively easy for us to move forward and agree that we were going to adopt them into the national PEWS and score for them. There's another 5 or 6 measures where actually there was relative disagreement. So maybe only 1 or 2 boards were using them, but because of how the safety work had evolved, a lot of discussion grew out of these measures about whether they should or shouldn't be included as we move forward with a national common language. And as we've grown in our understanding of deteriorating patients, an interest in actually adopting some of these measures. When we then asked teams what they did want to include, so not what was currently included in their chart, but what did they want to include as we went forward, again we had the same agreement of the heart rate, respiratory, saturations, conscious level, temperature and blood pressure. The discussions that really took the hardest amount of work, or the most discussion, was about including work of breathing or respiratory distress, and whether we should include that or not. Some teams felt very strongly that that was a good measure and it's what they used a lot locally, but we were concerned that we wouldn't be able to standardise that across the country. So actually, what was a respiratory distress measure of 2? Would it look the same in Inverness as it does in the borders? There's a huge amount of discussion generated out of whether we should or shouldn't include staff or parental concern in the charts or as a measure. Everyone agreed it should be included in the charts. Everyone agreed that they were using and listening to staff and patients if they were concerned, even if the PEWS was normal. And we really felt it was quite a powerful measure. There was a lot of discussion about whether we should actually add that into the scoring system or whether it should escalate automatically. And we did spend some further time looking into that as we moved forward with our national PEWS. We also had to decide how many charts to use and what age ranges. In actual fact, there was relative agreement. So even though it looks like there's huge numbers of variation in different age groups and charts here, they really fell into 6 age groups. Those less than 3 months, those 3 to 12 months, 1 to 2 years, 2 to 5 years, 5 to 11 years, and 11 or 12 and over. So it's actually fairly easy for us to get agreement about the age ranges. So we've agreed on the physiological parameters to include. We've agreed on the age ranges of charts. We then got into the discussion about, well, actually, what's in the score? How do you score? And actually what was interesting about the working group and how things move forward was actually the amount of information sharing that went on in the working group discussions about the various systems that were in use, about how to escalate or how to score. So in some boards, even though there might be agreement that a heart rate of 40 would trigger an escalation, it might trigger an escalation automatically. It might attract a score of 1, it might attract a score of 3. Some boards were escalating without adding a score. Some boards were using low scoring systems where you just added 1 for a physiological parameter that was out with a normal range. Others had a huge range of scores where you could range from a 0 to a 4 for each physiological parameter. And actually a huge amount of discussion then took place about, well, what scoring system should we use and how do we move that forward and who's in your escalation system. So actually how do we standardise an escalation system across country where we are having to look at patients who are looked after in small, remote and rural hospitals, primarily in adult settings, and how do we apply the same rules to quaternary specialist units. The biggest discussion about which system to use really fell into 2 camps. What we described as a traffic light system, so where a physiological parameter may score a 0, 1, 2, 3 or 4, depending on how far out with the normal range it is, or a binary system where a score of 0 or 1 was applied to a physiological parameter out with the norm. And this was really the mainstay for the next bit of information that we looked at in developing the National Paediatric Early Warning Score, of how to take things forward in developing that score and getting that common language. And that will be described in the next chapter.